Thank you, Professor Mahi, for this interesting subject, cleared. And now we shift for the next speaker, Professor Sharif Naguib. He will talk about auxiliary evaluation before neoadjuvant therapy for the treatment of breast cancer.
Thank you, Mr. Chairman. Dear colleagues, I was asked to present this talk about evaluation of the axilla before neoadjuvant chemotherapy. And I think it's a very tricky talk because it is full of debates, controversies, and until the present time, we haven't found the optimal answer to this question. When is the best time, and what is the best method for evaluation of the axilla? Now, the role of neoadjuvant chemotherapy in breast cancer has increased tremendously in the last few years. At the beginning, it was introduced to downstage inoperable disease to become resected. And then it started being used in downsizing large tumors to convert patients from modified radical mastectomy to breast-conserving surgery candidates. It also helps to evaluate the chemosensitivity of tumors in an in vivo manner. We know that tumor pathological complete response is associated with long-term disease-free survival, and these cases we see very often nowadays, patients who have no residual tumor after neoadjuvant chemotherapy. Same thing may happen with the axillary lymph nodes, where pathological complete response may happen in 30 to 40% of cases. We have to know two facts. The first one is that the response of the primary tumor may be different from that of the axillary lymph nodes. And we have to know that the beneficial survival effect of neoadjuvant chemotherapy is more evident in young women who are less than 50 years and who have hormone receptor negative tumors. Now, what is the role of axillary lymph node evaluation? Axillary lymph node evaluation is of tremendous value for breast cancer patients because it is the most important prognostic indicators providing accurate staging. It directs selection of appropriate therapy, and it predicts prognosis where pathological complete response is associated with longer overall and disease-free survival. We will be discussing the evaluation of axillary lymph nodes upon two pillars. The two pillars of discussion will be the different methods and the different timings. Now, considering different methods, we all know that the old standard was the axillary lymph node dissection, which was associated with high morbidity. So in 1994, the sentinel lymph node concept was introduced by Giuliano, which has become the standard of care nowadays. And very recently, many imaging modalities have been introduced to try and maybe avoid surgery completely by using non-invasive techniques such as ultrasound and fine needle biopsy or core biopsy, or 3D SPECT CT imaging, MRI, and PET-CT. The other pillar we will be discussing is the timing, whether before neoadjuvant chemo or after neoadjuvant chemo is the best timing, and we have to tell you that until today it is still controversial. Now, let's go back to axillary lymph node evaluation methods. Can we depend on clinical examination? This is a list of many studies that evaluated clinical examination only for evaluation of axillary lymph nodes. And as you can see, the accuracy was all less than 70% and completely unacceptable. So clinical examination alone cannot be depended upon. And this is the old gold standard, which is the axillary lymph node dissection of level 1 and 2, which used to be done to any tumor and any lymph nodes, whether clinically palpable or not. And the rationale was based on that even in T1 tumors, the incidence of lymph nodes may rise to 20%. And why do we not go higher than level 2? And that's because skip metastasis to level 3 does not exceed does not exceed 0.5%, and avoiding level 3 dissection may avoid lymphedema. Now, this is a picture of an axillary dissection where you can see the axillary vessels. I'm sorry, I don't have where you can see the axillary vessels here, which are, the pointer doesn't show, with preservation of the intercostal brachial nerves in a trial to avoid the complications of axillary lymph node dissection. Nevertheless, this is not morbidity proof, because still we still have complications, and their incidence is about 70%, while in sentinel lymph nodes, the complications rate is only 20%. And the types of complications we get with axillary lymph node dissection are numbness, pain, lymphedema, limitation of movement, infection, and seroma. So in order to avoid these morbidities and complications, Giuliano in '94 introduced the concept of sentinel lymph node biopsy for only clinically node-negative patients, and that was based on the fact that error rate for clinical examination is 40%. The contribution of axillary lymphadenectomy to disease-free and overall survival is doubtful until today, and based on the concept of orderly progression of metastatic cells from one lymph node to another in the axilla, and in a trial to avoid complications of axillary lymph node dissection. Techniques of sentinel lymph node biopsy vary in different countries. The dye used may be either radiolabeled sulfur colloid or blue dye or both, and with dual mapping using both together, we get the highest identification rate and the lowest false negative rate. There is ongoing research on using indocyanine green, and very recently some studies have noted sonographic microbubbles carrying Sudan black dye for the detection of sentinel lymph nodes. This is the injection of the dye, whether the blue dye or the radioactive sulfur colloid. We can inject it either around the tumor or retroareolar, intradermal or subcutaneous or intraparenchymatous. And this is the gamma probe to detect the sentinel lymph nodes. As you can see, they are also blue in color. And this is the excision of both the tumor and the sentinel lymph node with frozen section examination. And according to the result, axillary lymphadenectomy may be done or may be omitted. This is an intraoperative picture of a sentinel lymph node that has taken the blue dye. Now, there are different indications and contraindications for sentinel lymph nodes. As we can see, the indication is established for small tumors, even in old or obese patients. Nevertheless, there are some controversies involving the internal mammary chain, whether they should be examined or not, carcinoma in situ, pregnancy due to exposure of the fetus to irradiation, and even immunological problems with blue dyes. in large tumors, in multicentric or multifocal tumors, prior axillary surgery, prior breast surgery. All these are controversial as regarding the indications for sentinel lymph node biopsy. The results of sentinel lymph node biopsies are very satisfactory. The identification rate, the acceptable identification rate should be higher than 90%, and it has been reached in many studies. The false negative rate with the blue dye alone may rise up to 9.1%, and with dual mapping it is less, which is 6.7%. And locoregional tumor recurrence, when patients are avoided the axillary lymphadenectomy, is less than 1.5%. Recently, the imaging modalities of which you see the list here have been introduced to avoid surgery completely. The axillary ultrasound with fine needle or core biopsy for axillary lymph node evaluation has been introduced in the European literature about 25 years ago. It is indicated for clinically suspicious lymph nodes before embarking onto axillary lymphadenectomy. And the rationale is that it is a simple, non-surgical, and minimally invasive procedure, and it may omit one surgical intervention, since if the fine needle biopsy reveals to be positive, then we will skip sentinel lymph node and go immediately to axillary lymphadenectomy. And on the contrary, if it is negative, we will still do sentinel lymph node biopsy before embarking onto axillary lymphadenectomy. As you can see, the accuracy of axillary ultrasound for metastatic lymph nodes may reach up to 100%, but in these two studies, they were associated with fine needle aspiration. So ultrasound on its own cannot be accurate enough without biopsy. Nevertheless, it is not without disadvantages. The disadvantages of needle biopsy are the following. For fine needle, we cannot accept negative results without doing sentinel lymph node biopsy, because sometimes it may miss micrometastases. And if we resort to core biopsy, we are limited because we can only use it for large nodes, and it is hazardous to nearby neurovascular structures and may cause injury. These are pictures of axillary ultrasound. As you can see, positive lymph nodes in ultrasound appear as having cortical thickening with compressed hilum. Sometimes it is a focal cortical thickening like here. Sometimes they appear as completely replaced with loss of hilum, and sometimes they show as being hypervascular on Doppler examination. And this picture shows the needle that is introduced under ultrasound guidance into the lymph node for needle biopsy. Conclusions, the use of axillary ultrasound is growing. It is improving in safety, efficacy, and cost containment. The technique are improving and helping in improving sensitivity and specificity for regional disease. And due to the known inaccuracy of physical examination, complete axillary lymphadenectomy is still recommended for patients with positive axillary biopsy, even when clinically negative axilla is found after neoadjuvant chemotherapy. Another new imaging modality was introduced in Korea, and it's called 3D SPECT CT, which has two types, either a planar type or the SPECT CT is either planar type or a 3D type, and it is a combination of a single photon emission CT and a normal CT. And the combination of both systems may give a beautiful picture. I will show you one now of the axillary lymph nodes. And the advantages is that with the 3D, there is a better stereographic localization and identification of sentinel lymph nodes. This is the picture of the 3D SPECT. As you can see, this is the primary tumor, and these are the axillary lymph nodes in a 3D picture. I think with pictures like these, lymph node biopsy becomes far easier. Also, the MRI was introduced to avoid surgery in the axilla, and the criteria of suspicious lymph nodes are, as you can see here, irregular borders or high signal intensity on T2 weighted image, or marked gadolinium enhancement or round hyla with abnormal cortices, as you can see in the other picture. The results of MRI are very satisfactory and very encouraging. Nevertheless, these results were only reached with the use of USPIO, which is ultra-small super paramagnetic iron oxide, which is a lymph node-specific MRI contrast agent. And unfortunately, this contrast is not easily accessible and is very expensive. So to reach these results, to become duplicated again, I don't think these are very practical. Also, PET-CT was introduced, and as you can see, Greco et al. Has reported very good sensitivity and specificity percentages, and it may be introduced in the evaluation of axillary lymph nodes. This is a picture of axillary lymph nodes, as you can see, on PET-CT. We have to know that some factors increase the accuracy of PET in detecting axillary lymph nodes, like small-sized patients, not in obese patients, large-sized tumors, multiple positive axillary lymph nodes, and intense lesions. Conclusion, a number of imaging modalities can detect axillary lymph node metastases. Nevertheless, they are still unable to detect small metastases, and their sensitivity may be improved by the addition of needle biopsy, and we can conclude that no imaging modality can replace surgical staging of the axilla. Now, if we go to the other pillar of our discussion, which is what is the best timing for evaluation, whether before or after neoadjuvant chemo, and I have to tell you that it is still controversial. Some proponents of axillary staging after neoadjuvant chemotherapy have reported results which are varied and inconclusive. In a meta-analysis of 21 studies with a total number of more than 1,200 patients, sensitivity ranged from 67 to 100%. The negative predictive value ranged from 50 to 100%, and the overall accuracy from 77 to 100%, which you can see is extremely variable, and we cannot still reach a verdict until now. Evaluation after neoadjuvant chemotherapy does have some advantages, because we may spare some patients the morbidity of axillary lymph node dissection if they have no residual disease after chemotherapy, but this is not still the rule in all the studies that evaluate lymph nodes after neoadjuvant chemotherapy. Another advantage is that patients with axillary lymph node clearance after chemotherapy, meaning a pathologic complete response, have an increased overall and disease-free survival compared to those who have residual axillary disease. So evaluation after chemotherapy, as you can see, will help in detecting good prognosis patients. And one of the disadvantages of the evaluation after neoadjuvant chemo is the false negative rates of sentinel lymph node biopsy, which might be unacceptably high, reaching up to 22%. Why is the false negative rate after chemotherapy so high? We will show a slide immediately now. Here are some studies that evaluated the axillary lymph nodes after neoadjuvant chemotherapy, and as you can see, the false negative rates are all very close to 10% and above 10%, which are today unacceptable. So this is the main disadvantage of evaluation after neoadjuvant chemotherapy. Now, why is the false negative rate so high when we evaluate the sentinel lymph nodes after neoadjuvant chemotherapy? That's because the breast lymphatics may be plugged with tumor emboli, the tumor shrinkage that occurs due to neoadjuvant chemotherapy may cause architectural distortion of the lymphatics and affect the passage of the dye from the breast to the sentinel lymph node. There could be an aberrant drainage pattern of tumor emboli to multiple nodal basins and uneven sterilization of the lymph nodes where the sentinel lymph node responds to neoadjuvant chemotherapy while non-sentinel lymph nodes do not respond, leading to a false negative result of sentinel lymph node evaluation. Nevertheless, proponents of this technique, meaning sentinel lymph node after neoadjuvant chemo, have advocated that these false negative rates were reported only in earlier studies, smaller sample size because of limited experience, and in a meta-analysis of 69 studies, including 8,000 patients, the false negative rate dropped to 7.3%, which is comparable to the evaluation without neoadjuvant chemotherapy, and these are only some of the proponents. And they also say that the impact of false negative rate is not significant because the decision to give systemic therapy has already been made before evaluation. So even if we get a false negative rate, this will not cause under-treatment of the patient. And until today, as I was telling you, most studies evaluating sentinel lymph node after neoadjuvant chemotherapy still do axillary lymph node dissection for any patient that had positive lymph nodes before neoadjuvant chemotherapy, whether he has completely responded in the axillary lymph nodes or not. Conclusion, we need further studies where axillary lymph node dissection may be omitted in patients with negative sentinel after neoadjuvant chemotherapy, and these studies need to have larger number of patients with longer follow-up, and only if we can bring down false negative rates to acceptable figures. Now, another school is evaluating axillary lymph nodes before neoadjuvant chemotherapy, and it has also advantages and disadvantages. Of its advantages are the following, that it helps decision-making about the best neoadjuvant chemotherapy regimen, and it avoids potential confounding effect of treatment on axillary lymph nodes, and patients with negative sentinel lymph nodes before neoadjuvant chemo may avoid axillary lymphadenectomy at the time of definitive surgery. Nevertheless, it has a disadvantage, which is that in most studies, patients with positive sentinel lymph nodes, even if they get a pathological complete response after neoadjuvant chemo, are still treated with axillary lymphadenectomy. As you can see, these are different studies that show the results of evaluation before neoadjuvant chemotherapy, and as you can see, the identification rates are all close to 97%, even up to 100%, meaning that before neoadjuvant chemo, the false negative rates are very low. And this is the main advantage of evaluating axillary lymph nodes before neoadjuvant chemotherapy.
Professor Sharif, you have 1 minute.
Okay, thank you. Some authors have advocated doing the evaluation before and after, and the problem is the disadvantages are doubled. The optimal time is controversial, as I was still telling you, and in comparing between before and after neoadjuvant chemo, the best thing to do is to follow these rules. In patients with negative axillary lymph nodes for preliminary diagnosis, sentinel lymph node before neoadjuvant will accurately predict axillary lymph node metastasis, but patients with positive axillary lymph nodes at a preliminary diagnosis, it is advisable to do sentinel lymph nodes before and not after neoadjuvant chemotherapy. This is to compare them both. As you can see, when we evaluate before, we have better identification rates, but we have 2 operations to do, sentinel lymph node to be followed by axillary lymphadenectomy, while if we evaluate after neoadjuvant chemo, we have less identification rates, higher false negative rates, but we can avoid one axillary lymphadenectomy surgery for the patient. Thank you very much.
Okay.